So I'd like now to open the floor for questions and discussions. Also, if you want, you can ask your questions via the app of the EFIC. And while you think about questions that we would like to ask us, maybe we can start with the first question, was what can be criteria and limitations to investigate pure effects of analgesics or to detect patients more responsive to placebo, to minimize placebo effects on RCTs? Well, I think that's taking everything what we said so far from the other side. So we've been talking about maximizing placebo effects for the benefit of the patient. This question is asking about minimizing it so that drugs can probably be, better for patients. So I think everything we said so far is the importance of context and of doctor-patient interaction. And if you actually want to minimize the placebo effect, you should do what happens mostly in clinical standard care right now. That is, not talk to your patients a lot, not be very empathetic, and not have a lot of time. So maybe you also have some more comments on that.
I think this question addresses the also research, and as we said, the open hidden model is a very important model to extract the pharmacological effect of a medication. So this could be a possibility to divide pharmacological effects from psychological effects. And the second part is patients more responsive to which criteria to detect patients more responsive to placebo, to minimize placebo effect. I think what Sandra Kamping says and showed was the pre-attitude to medication, and I think this is a very important point too. So if you ask the patients for their pre-experiences and pre-attitude to medication, maybe this will be an interaction with the medication effects at all.
I think there's one question over there.
Yes, thank you. My name is Pirjo Lindfors. I come from Finland and I'm a pain physician, but I have studied psychological cultural anthropology about 20 years ago. And I would like to add to this discussion culture. I mean that it's not only about the social context when you are treating the patients or the patient and doctor relationship, but it's also that if you are functioning according to the value system of the patient, and if you are improving the meaningfulness of the life and taking account to their beliefs, according to the anthropological studies, it shows that there might be from 10 to 100-fold changes in the synapses. So I would like to ask whether you are aware of these medical anthropological studies concerning placebo. And if you are not, then I suggest that there is something very interesting that you could, because these studies can give you a hint where to go on a biomedical manner. And if you use this culture context, you can, the first context in the Western countries, it seems to be that, that people are very lonely. And I'm doing a clinical study on 450 patients, and I have noticed that at least in Finland, that is the biggest point. And if you bring the person into the context with the first person she or he wanted to be in a connection with, it seems that this is the best way of treating their pain. So there are very many ways to roam, but I suggest that you also add this cultural part to this placebo discussion. Thank you.
Yeah, thank you.
Okay, thank you very much for your suggestion.
Yes, there's one other question there, and then we go back to the IFIC app
You
thing.
told us that the effect was according to the previous analgesic drugs. For example, if we took if it's the mu opioid pattern of the cannabinoid pattern. My question, if it's someone has been exposed to the two drugs, will he have like a more efficient placebo effect than a patient who has only one previous drug? I don't know if it's clear. Or...
Mm-hmm. So if you mean if there is a pre-exposure of different drugs?
Yes. Will it be more efficient, for example, if I have pre-exposure only of one versus only of the other one versus the two of them? Would it be more efficient to have the pre-exposure or no?
Yeah, I think it depends on how you instruct these two pills or medications, and there are some models. I think you can say for one reason that one pill will take the side effects away, so the other one will be profit from the first pill. But I think it depends on the instruction of the two pills and their interaction of effects.
I think it doesn't really matter what we showed, how much or how many pain medications you've already tried and failed. The thing is that you need to assess this and need to directly address it with the patient. So if you just skip over it and the patient has already tried 5 different medications and they all failed, and you just add on a 6th one, then that would probably not be very good. But if you kind of like get into more detail why the other ones didn't work, or maybe stress that the new one has a different mechanism, then that might be positive.
Okay, thank you. And I have one last question. Sometimes in cosmetology, there is like, for example, 2 formula, and one formula is more efficient than the other one on animal testing or like pharmacologically, but the other one is well accepted and it's the best formula in the patient. Do you think that it's possible that for some drugs they are more pharmacologically active than others, and the other one is less? But thanks to the color, the taste, and it becomes that the psychological effect of drug A will be more than drug B, and so we have that drug A more than drug B, but pharmacologically only we will have a B more than A. Do you think it's possible, or?
Probably, because one of the pictures we showed was that the pharmacological effect of the different drugs was of course different, but independent of that was the psychological effect. And as these two make up the pain relieving effect, you can have smaller pharmacological and huge psychological, or larger pharmacological and maybe smaller psychological effects.
Do we have studies about like colors and smells? Okay. Yeah, I read about it. Thank you.
Okay, I'd like to take one more question from the app, and then we'll go back to you, which is, should we explain patients the role of placebo in our treatment, or rather we should avoid such education?
I think it's very important to talk about placebo effects with the patients, especially in in psychological pain therapy, because this is a very good argument for supporting the self-efficacy, what the patients can do by themselves to overcome pain, and therefore I think it's a nice model for the patient to see how they can by themselves do something against their pain.
Yeah, it was shown that it is really important to know how the placebo effect works, because it's an important information. So patients are aware that something is happening into their body and brain while acting also, while they are receiving and injecting also just an inactive pill. So absolutely, yes, it's important to explain. Now that we can say what is going to happen from a neurobiological viewpoint, is an information that is important to have for our patients.
Okay. So there was another question over there now.
Yes, thank you for the interesting workshop. I have a question that was triggered by the question of the previous colleague. It's about the generalizability of the placebo effect. So when people have to receive multiple medication, and there is a placebo effect for one medication, under what conditions will the effect generalize to another medication that is not being introduced as a placebo or as an open medication? Is there something known about the generalizability to different medication?
I think I only know one study from Ulrike Bingel and colleagues, and they changed the casing of a treatment, of a pain treatment, and they could show that by changing the treatment or the casing, a negative effect wasn't carried over to the situation, to the patient. So I think this is maybe one generalization, and how you can overcome the generalization effects.
I'm not sure if there was actually a study that looked at different medication where they were also targeting different functions, so maybe one for blood pressure, one for pain, and so on. But I know that there's one study on placebo from an American group that looked at different ways to elicit the placebo response. One was giving a drug, the other one was taking an ointment, the other one is a cream or whatever. And they also showed that the placebo responses, and this was in healthy subjects, but they showed that these placebo responses between the different treatments were not related. Or
They're
very
not related.
very small related.
Because I was thinking if the extra placebo effect is, for example, dependent on the casing, and you have to have another medication, you use exactly the same casing, would it also augment the effect of that new medicine inside that same casing?
Yeah, but I think also one of the important factors is the instruction. So how you shape the expectancy of the patient. It's not just that the pill has a certain color or that you take it always at the same time. Of course, that's important. But if you don't give any instruction, or
from the conditioning model, you would expect an effect of the casing as a conditioned stimulus.
I think this should work, as you said it. So because of the conditioning model,
something to further test. Thank you very much for your comment.
So there's another question that I thought is very interesting. Can you talk about the long-term lasting effects of placebos?
I'd like to say something. And, at present, we can declare that the placebo psychobiological effects last for some days. What happens later is not possible to assert if it is still a placebo effect or spontaneous remissions of the symptoms or something else which is different from the classical placebo effect.
Yes, I think long-lasting placebo effects are more difficult to achieve. There's one very interesting question that Regina wants to say something about, which is what do you think about the effects of non-pharmacological approaches? And we've been talking, all of us has been talking about boosting the effects of pharmacological drugs, and Regina has done a very interesting study.
Yeah, we did the same paradigm as I explained in my presentation with the back pain patients, and we changed the topic of the medication to a psychological treatment, namely a neurobiofeedback, and it works really in the same way as I explained with the big patch and the infusion therapy. So I think this encourages us to look more also to psychological treatments and boosting them by placebo efficacy.
Okay. Another question. I think it's the belief of patients rather than the therapy used which is responsible for the placebo effect. No belief, no effect. Yes, I think that's what we've been saying all along, that you induce placebo effects by expectation in the patient. And if you're not able to induce the expectation, then you won't probably see any placebo effect.
Yeah. I also want to say that there is some evidences, study in acupuncture, which show that patients who believe in the effectiveness of acupuncture has clinical responses. Otherwise, patients who does not believe in the technique does not show relevant effects. And again, important academical research have been demonstrated that patients with dementia who lose the ability to remember the verbal suggestions and information and to remember the history of previous medication does not show placebo response.
Yes, to follow up, there was one question to this, that the conditioned placebo response also works in the immune system. And yes, that's true, because the immune system is different from pain in that placebo effects can be induced there, but they require classical conditioning procedure. Whereas in pain, verbal instruction or expectation alone can be responsible for the placebo effect. But for the immune system, you need actually a conditioning. And that might be due to the fact that immunoresponses are not that easily accessible as, for example, the symptom of pain. So you can't really feel it that much, so you need to do something more. And then the next question is, are there personality traits that make patients more likely to respond to placebos or specific placebo paradigms?
Yeah, I think there are some studies, but I think we cannot say that personality traits will influence the placebo paradigms. But I think it's better to look at individually or at the history of the patients or the probands at all, and to assess the experiences with medication, for example. This would be a nicer model to prognose the placebo effectiveness.
Yeah, I can say that actually we can say there are at least 4 elements that can in some way predict if patients can be a good responders or not. The first one is the trait of personality, because if a person is an optimistic one, maybe it's more prone to receive and to accept verbal information than to be influenced by them. Otherwise, a negative person, a really close person, maybe does refuse this kind of information, so they are not going to influence his therapeutic outcome. The other element is the activity of prefrontal cortex. As I mentioned before, patients with dementia are impaired in these regions of the brain, so they cannot have placebo responses. Another important element is the efficiency of the nucleus accumbens. As I explained in my intervention, is very, very important for the nocebo-paralgesic response and placebo-analgesic response. And again, at last, the genetic component is also important. There are some studies which show that polymorphisms in the disease which are influenced by genetic polymorphisms are depression, and this depression is the best study. Also, the irritable bone syndrome. Sorry. So we can say that these are the 4 elements that are present, can modulate the placebo response.
Okay. So back to the question of patient education on placebo. Do you think that patients' awareness of placebo may make placebo effects larger? I think that's maybe a little bit difficult, because we were talking about enhancing the active drug. And yes, knowing about psychological mechanisms behind placebo effects boost these drug effects. I'm not sure if you take in a patient to the lab and if you do an experimental placebo study and you tell them the mechanisms behind placebo, if that actually has an effect. There is a study by Ted Kapchuk's group that showed that there is not necessarily deception necessary in placebo research. So you can tell patients that they will get a placebo, but then he went on and explained the mechanisms of the placebo and that this placebo that they got has been shown to be very effective in irritable bowel syndrome. And these patients showed large placebo responses even without the deception that is usually part of placebo research. Okay, and the last question we're going to take is actually the first that showed up the whole time, and now we're going to answer it. We've shown that there is no correlation between experimental and chronic pain. What about functionality? And yes, that came to my mind as well when I prepared this talk, and it's a very good point, and I haven't looked at it yet. I would expect that there might be a correlation between the chronic placebo effect and functionality, maybe not so much between the experimental and functional capacity, but I don't know because I haven't looked at it yet. Okay, I can't really see if there are any questions in the audience. I think no. So thank you very much for staying this long with us and this late with us. Please stay for the ethic closing ceremony. And if you're staying in Vienna longer, enjoy your time here.